Health disparities are a result of social factors, of inequality in income, education, and access. My research consists of HIV stigma and mental health, and how they interplay across racial and gender lines, and how the mental health symptoms actually can be exacerbated by things like HIV stigma and those lack of access to care.
We are working with rural and disadvantaged communities, specifically with the farm working community here in Homestead. We conduct focus groups, community forums, and we partner with community organizations to identify the social and cultural factors that predispose this population to substance abuse, violence, and HIV.
On a day-to-day basis, I explore the data that's provided by the CDC to look for opportunities for interventions. These data is more than just data. It's people's lives.
Good morning. Good morning. I'm Dr. Yogi Hernandez Suarez. I am the Vice Provost for Population Health and Wellbeing, and on behalf of FIU and DC and also the Office of the Provost, I welcome you to what's going to be a very invigorating and thoughtful conversation. Today is day 2 of our program here, our fly-in to DC, focusing on coronavirus as a catalyst for change. We welcome back our fellows. We had an extraordinary day yesterday. I know I learned a lot, and I imagine that you all did too. We welcome to this conversation also members of our FIU community, as well as friends from the Hill and others. And it is my special privilege to welcome Congresswoman Donna Shalala, who will frame our conversation and kick off this session. I can think of no one better to help us think through the role of universities and their impact on health and community than Donna Shalala, who has led universities, led our country's health and human services, and is my congresswoman, our congresswoman from FIU for our district. It is a privilege to welcome you, Donna Shalala, and we look forward to hearing your thoughts.
Thank you very much. Thank you. I'm delighted to be here, and I want to salute all of you for spending time this morning on a very important question. Universities as catalysts for positive health prevention and improving health equity. And that's exactly what universities ought to be doing, particularly the great research universities like FIU and the others that are represented here on the panels. Let me say a couple of things. Number one, I think this is going to be the golden age of public health. Never before has it been so clear that public health students trained in our universities, in our schools of public health, and the issues that focus on public health, particularly the issues of disparities, are more important than they are during COVID-19. We've learned a number of things about this epidemic and about ourselves. But more than anything else, I think we've learned the importance of universities and all hands on deck. Most of these hands are already passed through the country's universities in some fashion and must be supported by the federal government. Look, tracking the spread and managing data with our epidemiologists, speeding up vaccine development by our scientists, protecting doctors and nurses that are treating our patients and creating public health promotion strategies. The case has been made for doing even more with and for our schools of public health. And I want to salute FIU for its important work in responding to these needs in the greater Miami region and being on deck nationally as our country seeks solutions. In particular, FIU's focus now on the disproportionate impact of COVID-19 in unrepresentative racial and ethnic minority populations in the United States. In my district alone, if you look at who's getting COVID, it's low-income minority neighborhoods, multi-generational families living in relatively small quarters, in which some members of the family have had to go to work. And they come back often, too often infected and infect the rest of the family. It's not what the press is reporting, a bunch of teenagers and people in their 20s that are going to bars. I'm sure that they're passing on COVID to their parents and grandparents. It's actually people that are going to work in low-income neighborhoods. In addition to that, if you look at what's happening in nursing homes, it's really the workers, many of whom are underpaid, who have more than one job, who brought COVID back to the assisted living facilities. So focusing on underrepresented minorities and on low-income people who may not have very good health care. Even though in my district, I have the largest enrollment in the Affordable Care Act, Miami-Dade really is heavily involved in the Affordable Care Act. We still have too many low-income workers that don't have any health insurance. We haven't expanded Medicaid. And because they don't have health insurance, they don't have access to regular testing and access to the kind of treatment that we need to be able to contain this virus. Let me also say that one of the lessons of public health is that we shouldn't only focus on high tech. Public health has extended life over the years, much more than all of our scientific breakthroughs, with the exception of vaccines. Clean air, clean water, code enforcement in housing, all of those things. And now we're faced with the fundamentals of public health. Wear a mask, wash your hands, practice social distancing. And one of the things I want the students to remember is that public health is a combination of scientific strategies to contain and starve viruses in this case, but also of the most fundamental and simplest approaches, and that is wearing masks, practices social distancing, and washing your hands. Washing your hands may be one of the most effective things we've ever used in public health, and the combination of that and social distancing and wearing masks is just a powerful reminder, number one, that we shouldn't politicize any of this. I think it's crazy to do that, but that we can contain a virus. We can reduce the number of lives that are lost through the most straightforward approaches. And universities have an absolutely critical role in this, as we do in the use of vaccines and the distribution of vaccines. The National Academy of Medicine recently released a report called an equitable framework for the distribution of the COVID vaccine, an equitable framework. It focuses obviously on first responders and on seniors in nursing homes. Those are the most at risk, people with underlying health conditions and minority communities. So I think it's extremely important what you're doing today. Universities clearly can lead the way. They have the clearest voices, the clearest nonpartisan voices in our community. So I'm delighted to be with all of you today. You have a big responsibility. But again, let me repeat, I can't think of a better time to be studying and be a professional in public health, because the challenges in front of us will be with us for years to come. And it will only be the universities, the great research universities, that train people to anticipate the future, because that's what we have to do. Thank you very much.
Congresswoman, that's extraordinary, and we know we can always count on you to keep it real and keep it impactful. And so we couldn't agree with you more. I do believe we have time for just one question. We know you are time constrained. We have a student. Ian, would you care to pose your question to the Congresswoman?
Sure. Thank you, Dr. Congresswoman Shalala, thank you so much for your comments. My name is Ian. I'm a doctoral student in public health here, and my concentration is in health disparities. And my question is around how you are able to speak to these issues that become politically charged. So, for example, I've had a hard time speaking to certain people and just talking about what just that health disparities, that they even exist, that the idea that there is systemic discrimination, systemic racism, it's become a hot button issue. And my question is really just around how you navigate, hot button topics and make progress in Congress.
It's very important. Everybody says you got to stick with the science, you got to stick with the public health, and communications turns out in public health to be one of the pillars, unless we're clearly communicating. I wrote an op-ed the end of February for the New York Times, early March, I think they printed it in, which focused on the pandemic and communications. And it's who speaks to the public and whether they speak with one voice. And let me give you an example. Whenever we had some kind of a scientific breakthrough or a public health outbreak at HHS during my 8 years as secretary, I never allowed politicians to talk about it. I never had a press conference at the White House. The press conferences were always at the department, and it was always the scientists that introduced the subject and described the subject. I worked with them to make sure they were all on the same page and they all spoke the same language, because sometimes scientists have more nuance than they need to when they're talking to the public. So they have to understand the constituency they're talking to. But I made them wear their white coats. That was the key. It was called the Shalala rule. And they had to put their white coats on, whether Tony Fauci, David Satcher, Harold Varmus, whoever they were, the docs and the nurses, they had to put their white coats on. The public trusts those voices. And what we've lost in this pandemic is that trust, because the politicians have stepped all over it. And politicians should get out of the way and make sure that the public health specialists and the scientists, all of whom are scientists, speak with a single voice that's clear in every language we need to speak it in. And frankly, I wouldn't make it too complex. The mask issues, where you're protecting your family members, you're protecting your grandmother, resonates in Miami, because everybody loves their abuela. And so we've got to say it in ways in which families understand that they're protecting each other and they're protecting those that they love, in addition to protecting themselves. But the most important thing is to protect everyone we love. And that requires that we exercise certain behaviors. And there's nothing complex about those behaviors. We'll get there. We'll get there. We just haven't had the national leadership that's consistent. But the one thing I've learned about public health is that communications is as important as getting the science right.
So much.
Thank you, Ian.
And I know our time is ending, Congresswoman. As you leave us, I do want to obviously thank you for this insightful time, and also recognize that you have hosted and continue to host our interns in FIU in DC, and we are grateful for that. That has made changes to their lives and to our institution. And we continue to hope that you will take our students under your mentorship. It means a lot to us.
No, I'm always happy to have FIU students, particularly in public health, and they seem to have had a good time um, during the period they've been with us. I'm sorry we're doing some of it in person in Washington. We can't do that much of it here, but we'll continue to do it. And thank you very much for the invitation.
So appreciated. Thank you so much, Congresswoman. Stay well.
You too.
Wonderful. So I'm now going to turn to introducing our two panelists, and then we will have a sort of a roundtable discussion of some of the questions that we've prepared, but we want to leave plenty of time for our students to be able to interact. Let me introduce first Dr. Virginia Brown. Dr. Brown is assistant professor at University of Texas in Austin and at the Dell Medical School, and she is in the Department of Population Health. Welcome, Dr. Brown.
Good morning.
And I'm introducing now Dr. Electra Plaskett, and she is at Ohio State University. She is the Marion N. Rowley Professor of Cancer Research and Associate Director for Population Sciences and Community Outreach. Welcome, Dr. Plaskett.
Thank you. Good morning.
Perfect. Well, you know, it's hard to follow Donna Shalala, who kind of said what's in all of our hearts, but I think we can put some meat on the bone, given our own experiences and the regional areas that we represent on this panel. So let me start with you, Virginia. If you could give us just a few bullets of how you and your organization are leading in this space of the intersection of universities and community health.
Well, thank you and good morning. I appreciate the opportunity to be here. A couple of things I was thinking about. As you know, Dell Medical is brand new. We opened in 2015. I came from Washington, D.C. in the summer of 2016. And I just want to give you a couple quick highlights about how we opened and how we opened differently. We opened with the Department of Population Health. We opened with a community strategy team. The community strategy team at that time represented 9 individuals from the Austin community who were various activists who were actually paid to, if you will, speak truth to power, bring the insights of the community to the leadership of the institution. So we started with the strategy team. We started with an associate dean of health disparities, now having, as you see my son in the back, we rethink everything. Having rethought that with an associate dean for call it what you want, health equity under the leadership of Jewel Mullen. We started with a moniker called an eye on the health ecosystem, loosely translated to an eye on understanding that 80% of health really starts outside of the walls of the medical encounter. And that's the challenge that we have right now, is figuring out how to, in the framework of a medical institution, how do you reach community? How do you incentivize research? And how do you value that when you're a researcher like myself? So those are just a couple things I want to add. One last thing, we also opened with a division of value-based healthcare. So we opened very differently. We thought about these things very differently. We are still challenged by these things. So I'll save that for further discussion.
Wonderful. And Electra.
Yes, good morning and thank you for inviting me. So I'm from The Ohio State University, and I'm going to give you a slightly different perspective. We do have a School of Public Health, which I am a professor in, but I also have a leadership role in Center for Cancer Health Disparities in our Comprehensive Cancer Center. And we realized many years ago, almost 19 years ago, when I came to Ohio State, that we needed to address disparities. And this center has grown over the last 19 years, and we focused on a community-based participatory approach to engaging all of our communities and our catchment areas, the entire state of Ohio. You might not think that Ohio is diverse, but it is extremely diverse. We have rural populations. 50 of our 88 counties are rural. We have 32 counties that are Appalachian, that have some of the most socioeconomic challenged communities in our country. And we also have diversity in terms of Black, African American, Hispanic, and many immigrant populations. We actually have the second largest Somali population in the United States here, actually in Columbus. So we have large diversity. And so my Center for Cancer Health Equity, from the wonderful support we've gotten from the institution, has now a staff that matches the demographics of our community. And we're able to go into the community. We speak to the community, we listen to the community, we understand the community. This network that we've created has been very helpful as we try to understand this whole COVID pandemic and how to assist our community members in addressing it. And the last piece I'll just mention about this is that our center, we don't do this just for us. We don't do this just to get research grants. We use what's called the give-get model with our community. We help the communities, for example, to write grants that all the money goes to them. We offer continuum of care navigation, where we use community workers from the community, link community members to our navigators for essential services such as breast and cervical cancer screening. And we're moving into other screening modalities also. And it's always with a focus on making sure that the social determinants of health are met, as well as addressing barriers to care, including insurance, where to go get the tests, and through follow-up of treatment, et cetera. So I'm happy to answer additional questions as we get our discussion going, but that's just a little synopsis of our work in the Center for Cancer Health Equity. Thank you.
So I'll just add that a common theme that you both have, and I am fortunate to have as well, is top-down support for this work. So one of the things that is very challenging and I think has evolved over the at least last decade is the recognition from senior leadership that this work is not nice to have, but this work is critical and is part of a strategic plan. And that has really, I think, changed the opportunities to have impact around these areas. So my role as Vice Provost for Population Health and Wellbeing is a year old. It was through the leadership of our Provost and President that this role was created to use the platform of the enterprise of FIU, as you have heard, the fourth largest university in the United States, figure out how we can leverage the entire enterprise for health, and health for our own Panther Nation, our Panther alumni, and the communities that we find ourselves in, whether those are local or global, because FIU really has a pretty impressive global imprint beyond South Florida. And I think it's, we have to give some props to our leaders who have bought into the strategic value of investing in the tenets of population health and what they mean for higher ed. And so I think this work would have been almost impossible, if not at least a bigger slog than it already is, if we didn't have that top-down leadership. So props to all of the leaders from the medical school at Dell, which is obviously very intentionally built to create contemporary physicians. I applaud. And then the work that I think is longstanding in OSU around the health of the OSU community as a university, as well as now the broader community. So we have to talk about coronavirus, right? So I came to the university to do this very, lofty work around changing the platform of the university for health, and honestly have had to completely rethink my time and energy and to answer the call to be responsive to the reality of the pandemic. Because there's no next if we don't get through the now, right? So I have been asked to set up the COVID response team through the Office of the Provost. We are doing a lot of very specific work in screening, contact tracing, tracking, population health analysis of trends. And, I think nothing has shown a light more on the fragility of communities in this country than, as Donna Shalala stated, than this pandemic. It is the time for population health, and it is the time to use this crisis to not come out of it the same, right? I've had a leader who told me once, Yogi, never waste a crisis, right? So I told the fellows yesterday that I do believe that we will have a point in time that is before coronavirus, and that's BC, and then there's AC, and that's after coronavirus. So let me ask you, Virginia, specifically around coronavirus, what are you doing as far as your learners are concerned, your faculty are concerned, and how you, as a new and a light is on a new medical school, how are you using that platform to gain leverage at the broader university level and also in community around coronavirus?
I'm going to take your phrase, never waste a crisis, and do a public service announcement for being an ethicist. I come to the medical school not being hired as an ethicist, but that is my background. I am a medical sociologist with a master's in philosophy. I have been a clinical ethicist. I've served at the bedside. I think deeply about the issues of social justice and autonomy. So in this particular moment, I am working with my colleagues in internal medicine to take a look at our data set that's been collected. They created a dashboard in particular around COVID. And we're asking the question, if we go into a scarce distribution model, okay, what is the impact going to be? Now, we know intellectually the impact of a scarce distribution model for distribution, for the issues of justice, when we think about ethics as justice and distribution. We know that it favors those who are young, those who are thin, and those who are white. But when you work in a medical hospital, in particular in a medical school, that's just anecdotal evidence. They want to know, where is the empirical insight? And I'm like, just think about it. What do you mean, where's the empirical insight? But I know that I'm in a foreign land and I need to learn to speak the language of the natives who are there. I'm bringing new language to them. So we're in the process, we're tussling back and forth with the IRB to move through the data that's already there. They have put in measures of social determinants so that we can think about what is an ethical distribution, one that rethinks the typical paradigm, okay, of who is deserving. Because if you use that deserving model and you look at the folks who are most impacted, you will violate the Belmont report every day, every time, every time. And what I'm talking about is the concept of not burdening those who are already burdened. And so we're going to look at that data, run, what we would think of as a philosophical discussion, but with empirical evidence, to then think about what would an ethical distribution look like. And we're going to do it through community engagement. CBPR, community-based participatory research, is the backbone of our department. It is the backbone of most departments of population health. So how do we bring community in, and how do we bring in our colleagues from the iSchool, the School of Information, who are doing AI models and asking questions right now? This is a project we have, it's called Good Systems. It's at the university level that's asking questions about, how do you create an ethical AI algorithm, if you will? And I don't speak AI, so if I'm botching some of that, please forgive me, but I think you'll understand that the need to look at algorithms and look at the problems that we've had with them, because we're human and human beings have made them. How can we rethink this? So that's the most powerful thing that I am actually working on, that we're trying to bring attention to, as well as the everyday kind of work. We're working with the city, we're working with Austin Public Health. We have a contract to do contact tracing. We've been working on that, working with the students, doing a range of different engagement with them. But I think this is a different approach to the conversation. It's about scarce distribution and the ethics and the social justice impact. And I really want to emphasize that as something different and critically important.
Well, you know, and I want to call out to the students that none of that would happen if Dell hadn't had the foresight to bring a different kind of a non-traditional person to a decision-making table. And that is, and we spoke yesterday about the wicked problem that is population health and how cognitive diversity is needed at the table. And I'll call out, you see yourself as a translator, and I do too. I straddle, my career has straddled the health systems administration world, having been in a hospital administrator, having been in the payer space, and in the private sector, in the public sector. But I feel like I am the Rosetta Stone of discussing, you know, rationing and scarcity, coming from a business background and an understanding of how money flows through our healthcare systems. And so, but the position at the table, at the decision-making table, has been hard won as a doctor, as an MD, and as a businesswoman, and then now cracking into academia, which has its own language and its own coin of the realm as well. Mm-hmm. It has to be a lot. I say that this work is, you have to be open-minded and open-hearted, and you're going to hear a lot of different kinds of folks at the table. And part of this is, you know, you got to be willing to listen and value and respect different voices at the table. So how about you, Electra? I'll give you the same opportunity to showcase coronavirus-specific work.
Right. I'm going to address two issues. First, many of you know all around the world, there's been a shift to more telehealth visits. Mm-hmm. And telehealth visits also exacerbates disparities, as does this whole COVID-19 thing in itself. But the thing about telehealth visits is they don't all have to be video visits. They can be audio visits. And, you know, our team gave me some data in that, you know, 38% of our telehealth visits were audio visits only. And, you know, almost half over the age of 66. So, you know, if we cannot be so rigid. I like what Congresswoman Shalala said about, we don't have to have the whiz bang stuff. You know, the telephone can work just as well. And what this has resulted also is reduction in missed appointments, and especially in the Medicaid population, a significant number of reduced visits. So, you know, that's one address and perhaps one area that we have started to address disparities. The other one I want to talk about is our response to COVID for our minority, underserved, and vulnerable populations. Many of you might know that the director at the NIH put out a call for applications for RADx Up, which is an initiative to use your existing networks to go out into the minority, vulnerable, underserved populations with education, access to testing, contact tracing, and follow up on treatment to these populations. And so what we did was we partnered with the Ohio Department of Health, who was already doing a wonderful study on where COVID is going to hit the hardest in these specific populations. And they did an analysis, and they identified communities within counties which are the most vulnerable. We use that, as well as our connection, our networks that we have in the Cancer Center, as well as our CTSA led by Dr. Becky Jackson. And we were successful in our application. And so we are going to be focusing in 12 counties in Ohio in the vulnerable communities as identified by this Ohio Department of Health report. And we are going to be using the continuum of care navigation model that I explained a little earlier, and working in partnership with local community centers, which is our entree into the community, such as federally qualified health centers, the health department, et cetera, community-based organizations, to hire local community health workers and begin this initiative. And we're very excited about this. This will also allow us to roll in some of the initiatives that Ohio State is developing in testing. And then, of course, the idea of the director of the NIH is that once we do have a safe and effective vaccine, that these networks can be used to also distribute the vaccine in a more equitable manner that we talked about earlier. So those are a couple of the things that are going on at our medical center in response to COVID, as well as at the university. We have a dashboard, and there's been a lot of very good work done with the students and the faculty, both off campus and on campus.
Wonderful. And just to toot our own horn, FIU was also a recipient of one of these RADx grants under the leadership of Dr. Mariana Baum in STEMPEL in our College of Public Health. And so we are also collaborating with a community health center to understand impact of testing in special populations. And so, grants and is certainly one way in which universities collaborate with government to move missions. I want to leave time for the students to ask questions, but I want to then just ask, because as a public university, we are very much tied to our state and its objectives and our state legislature. You can see that we have close ties to our federal representatives in the legislature. Maybe, Virginia, you could just, describe how you think in the space of population health, beyond grants and dollars and funding for programs, how do you think we should be approaching government, both local and federal, to move work in this space?
So I don't know what all of your students have studied, but I will say this. I'm my PhD, sociology, my theory lens, historical materialism. So my conversation is always about the political economy, right? And so when I'm thinking about what are the models of funding, how are medical schools in particular funded, and how does that funding carve out the opportunity to investigate community health as a stand-up pillar? So the specific thing is the funding model doesn't allow you to do that. So there's two answers. I really want to lift up the work of PCORI. It's a total shameless plug, but I also have a PCORI award for a community engagement. PCORI understands, and that's called Patient-Centered Outcome Research Institute, is PCORI. They are a quasi-governmental agency. They're right there in Washington, D.C., but they get the fact that engaging community partners, patient partners is how they describe it, is essential to changing the trajectory of what happens in health and healthcare. And they also understand that to do that, you have to treat patient partners like stakeholder partners and reward their time and energy and knowledge, just as you would if you were asking for a consult from any of us. And that's a game changer when you're moving into community, because you're like, you're back here to pick my brain again. I don't have
for free.
For free. We call it RFF, request for free stuff, right? It's like, I can talk to you over a coffee, that's fine. But if you really want me to change something, you need to hire me. So standing up more agencies like a PCORI, changing the way and the emphasis on federal funding that recognizes there needs to be a line item in there for community engagement, for community advisory boards, that we need to have these as standard components in calls for proposals, I think is a really critical and important thing. And lastly, I want to add this. One of the challenges to being in a medical school and being a PhD, a non-clinical PhD, right, is, am I really an NIH researcher, right? If I'm thinking about issues of promotion and tenure, is that the gold standard when you're talking about wanting to do community work? Well, it might be if NIH infused that deliberately in their work and said, we value and we support financially you doing the engagement, different than a CTSA, right? different than a translational science award. I'm talking across all the institutes. That would be a powerful game changer, because having to navigate the promotion and tenure component where it's broadly understood that NIH R01s are the gold standard, you really have to figure out, and this is really to the students, if that's the space that you want to be in. The lab that I run, my three folks who are in my lab are a health communications scholar postdoc, and a graduate student communications, health communications, and a demographer graduate student, right? Totally untraditional, okay, non-traditional spaces. So how do we think about bringing that in and infusing that across the institution and as a valuable contributor to what medical schools do? I think thinking about the funding and reprioritizing that. And I'll close with this thought. I did do a little homework. We're in the process of standing up a fourth pillar, right? So when we think of typically our pillars are clinical for the physicians, teaching for those who do the teaching of the medical students, investigation, that's the space that I'm in. They're standing up in the process of standing up a fourth pillar, community impact. Now, standing up a fourth pillar of community impact is a game changer. My question is, when you say to me that my team needs to be covered 100% by external funds, I'm like, this is a real challenge. Okay, this is a real challenge. So in thinking about the community impact, what are the measurements? What are the returns on investment? How do we recover that money? How do we infuse it back into the institution? And how do we bring in and maintain staff? And I mean staff broadly. How do we staff up these projects when we're always relying on external funds to staff them up? The risk of the knowledge that could walk out of the door is very high. These are very talented people. And if they're always on contract, what kind of career development does that allow in the institution? Those are some of the challenges that I think we have to think about when we say, how could funding at the federal level change and be more uplifting? It can rethink the value of this kind of work and make it explicit in their calls for proposals.
I love that. Obviously, I hear you. I had a mentor who told me once, Yogi, show me your budget and I'll show you what you care about. That's it. That's the whole story. And I'll quote my dad, who says, don't tell me you love me, show me you love me.
Yes, absolutely.
Electra, anything you'd like to add to Virginia's conversation?
So I have a little different perspective. I also am a PhD in a medical school, and so I totally share what you said. However, I have seen some change at the federal level in terms of the funding sources, as well as several institutions. The NIH, mainly the National Cancer Institute, where I get a lot of my funding from, has really moved to appreciate and fund, big funding, community-based participatory research, and the new kid on the block, which is implementation science research. I have a large program project grant that is implementation science funded by the National Cancer Institute. Many years ago, that would not have even been considered. But there has been a lot of change to appreciate this type of research, and especially community engaged, community-based participatory research. And it is finding a place, it is finding value. And it has been an uphill battle in terms of saying that, what we do is science. It really is science. And with this new kid on the block, implementation science, that's really how we're going to reach, and especially reach our communities and reach our diverse communities, because it's not us going in, with our gold standard randomized controlled trials, 20-page consent forms, which not going to work. But we're teaching the communities, we're teaching the practitioners how to take better care of their communities and their patients. And that will have more effect and be more long lasting than us coming in there and doing our stuff and then leaving. And so that is really, I'm very excited about this new type of research. And we have about 4 or 5 studies, including our RADXUP is going to be done this way. And so I'm real excited about it. So my team is very, very not only racially, ethnically diverse, but also from the disciplines that you mentioned. And we work in transdisciplinary teams because that's the way we need to move things forward. And our institution has gotten a lot more recognizing, they've become more recognizing of people who work out in the community in terms of promotion and tenure and things like that, and the value of the type of research that we do. So I guess, I'm always a more half full cup rather than a half empty cup. And I think that, we need to keep showing the value of this. And
Yes.
And your comment about how you work with your legislative officials, I would really appreciate if more of them had the perspective that Congresswoman Shalala about that, let the scientists talk and let the scientists be the one that you listen to instead of discounting us, and saying that it's, false news. We're not false news. And I feel that a lot of times is that we are not respected for our knowledge and our experience, of how to address this. And COVID is really bringing that out,
Well, just to put a fine point on it, which I think we all agree, is whatever's going to happen with the people like us who are trying to move multidisciplinary, intercollegiate, cross everything work, it doesn't happen organically. It only happens with intent, and it only happens when you keep at it. This is having trained in Iowa, this is a hard row to hoe. And so, it takes energy, and it takes consistent pipeline of new voices. And that's why for us, at least for me, I'm sure for you all as well, it's so exciting to be at a university, because you see the substrate that's coming and the opportunity, hopefully to get this figured out better before I'm on Medicare. So that's you want to get that Medicare stuff really shiny. You got about, I'm not going to tell you, but you have less than 10 years.
They got a short window. I'm carrying my AARP card too, so.
So I would like now to turn to our students, and Eric, if you have some questions that you can channel to me for any of us, we are open to those.
Great. So what I'll do is I'll ask students to chat their questions into the chat. I'll call on them to read them to you and our panelists, but that's a preferred way in this format to keep track of the questions that are here. And while we're waiting for those, we do have our esteemed colleague in the STEMPEL College of Public Health and Social Work, Florence Greer, who had put a question in the chat pretty early on. Florence?
Hi, thank you, Eric. Good morning, Dr. Yogi, Dr. Brown, Dr. Pesquet. Thank you, FIUNDC. This may be geared towards you, Dr. Brown, but and maybe Congresswoman Shalala if she was still here, but we're in such a politicized environment. How can health equity and social justice prevail when our elected officials state that systemic racism does not exist?
That's a really good question, and I have an answer for you. I think the personal is political, right? And that a lot of this tussle back and forth is not understanding that it is not per se the melanin in my skin that makes me deficient in this particular way. And I always pause and go, but I have vitiligo, but that's a different story, okay? But clearly, as a Black woman in America today, my dad is 91, my mother's 86. We've got longevity in my family. So I'm telling a different story here, people. So what that means is this, that we have to find in telling this story of systemic racism, it is about marginalization, and white people are marginalized as well. And it means marginalization occurs when you're poor. You have to know your history. You've got to go back into the early 20th century. You don't have to go back too far to understand Bell versus Buck. You have to understand what eugenics looked like for poor white people. That was a systematic approach to weeding out the feeble-minded in this country. And when you can look at that, you can look at some of the policies that came out of that and personalize it. People can, I think, begin to better understand what structural inequity looks like. These are policies and practices. They didn't just fall down out of the sky, okay? They were designed to be in service of the political economy. When you go through and look at how policy gets developed, just start back at the beginning of the 20th century and go forward. Understand what was favored, what wasn't, and how we made decisions about who we tested on, okay, and who we didn't. If you were an orphan, okay, if you were a conscientious objector, if you were in prison, if you were poor, if you were of color, your characteristics are you're outside of the political economy, you're at the margins of the economic engine of this country, and your agency was at risk. And policies were written to use you, to not recognize your autonomy, and to use you in service of the state. And when we can go back and pull those policies and we can point to them, I think we can engage in a different kind, I hope, a different kind of conversation that says we are all at risk. This isn't just about being Black and being brown, okay? We are all at risk in a country that can do this.
I love that answer. You know, and part of the role of higher education is to instruct people in that history, right? I think because, you know, history has been owned by the very people who create the bubble
institution, yeah,
ourselves, we perpetuate, and it's only the people on the fringe as we try to claw in to get as I say, a place at the table. And it's exhausting, right? Let's agree that there is a burden that comes with that. You know, universities are uniquely positioned to be, with our academic freedoms, with our platforms, we are unique. We have a unique obligation to break through some of that. I know we're getting near our time, but I'm going to ask both of you, can you stay on for just a few more minutes to field one or two more questions?
Sure. I'm going to look away. I've got to text a couple people and tell them I'll be a few minutes late. But
that we are totally okay with that. If you can do that, that's great. How about you, Electra?
I got about the 5 minutes.
Yeah.
Okay. Well, we'll try. Let's try one more question then from our students.
Perfect. I saw Vicky had her hand up, but this item just chatted it. So Vicky, over to you.
Hi everyone, my name is Vicky Vasquez. I'm a current doctoral candidate in public health, studying health promotion and disease prevention, and I'm also a health disparities research fellow with an endowment grant with NIH. So my question is for all panelists. I think given the value of external funding and the expansion of the curriculum and training in medical schools, specifically for health disparities training and looking at social determinants of health, how do we continue to lead in exploring this intersection between the effects of climate change on COVID if there's no institute in NIH specifically for climate change?
Okay, so we gave you an easy question right here at the end. Electra.
Well, again, I don't research climate change, but you know, how do you do anything that there's not necessarily a specific institute? You just do it, and you make your case that it's specifically, you know, important. There didn't used to be an institute for health disparities. And, you know, we've been doing health disparities research, many of us, since the early 1990s. So you do it and you make your case for it until there is an institute. And, you know, it's like you have to do this research to get the institute. The institute's not always going to come first and then the research. And I want to talk about the first part of your question, which deals with the expansion of curriculum and training. in medical schools for health disparities. I want y'all to tell me what your training is across all of the medical schools. You know, how much training is there? I give one lecture to medical students the first week that they're in training on the social determinants of health. That's it. That's it. Now, Dr. Gray, who's my deputy director, and I give this lecture, and we also always have a panelist from the community. This year, I can tell you, we did it virtually. My panelist, who is also one of my community health workers, Somali health workers, got 90 comments from the 100 and whatever medical students about how fabulous she is. She is. That is mainly how our medical students are learning, you know, one lecture. We offer a summer research program on health disparities, and we always open it to the medical students to come. And we've trained several medical students over the years. We've been doing this along with students from historically Black universities and colleges. And the medical students love it. The undergrads love it because they, you know, they learn a lot. But we have to look, we have to start. If we are really engaged and really serious about addressing health disparities, addressing climate change, you need to be the agent of change, and you need to do it, because nobody's going to come and say, I want you to do this, because you have to do it. And then you get the way, you find the way to do it. If there's a will, there's a way, and you can do it. You're muted, Yogi.
I love that, Electra, and it's been our experience for any provocative intersectional work. Women had to carve out research space for our own understanding of our own pathology. In the obstetrical space, we are now trying to elevate a discussion around maternal mortality, which is, you know, shocking if you just stop and think about it. But there ain't no institute, and so the question is how. And I love Virginia's statement. You know, you got to speak out, and in the coin of the realm of academia, we must publish, we must publish, we must publish. So I'm so grateful to both of you. This has been a delight for me to have this, you know, conversation with you. I hope that we find ways moving forward to help each other. It's a tough space, and our universities are in varying places in their evolution in this space. And I think nothing else that this leads to some friendship and future collaboration. So thanks to both of you. And we appreciate how generous you have been with your knowledge with our students, and how real and forthright you have been with your journey. So thanks to both of you, and thanks on behalf of FIU in DC and on behalf of the Office of the Provost. I would like the students to stay on for a moment. We do have a representative from the National Hispanic Congress. Carlos, can you help us tee up Winta?
Yeah, this is really just a 30-second commercial, if you're able to, Winta, for not only our students, but all of our guests, the Congressional Hispanic Caucus Institute's upcoming Health Summit.
Absolutely. Thank you so much for the opportunity. And thank you so much for the invite. This was really fantastic. So for those of you who may not know about the Congressional Hispanic Caucus Institute, we are a 501c3 nonpartisan nonprofit organization. Our mission really is to develop the next generation of Latino leaders, but a big part of what we do is to also convene, where we bring together people from the private sector, the private sector, the public sector, as well as the nonprofit sector, to talk about issues that impact the Latino community. And one of the things that we wanted to do this year, actually originally we were planning to do it in April, was to convene a health summit to talk about health and healthcare issues that impact the Latino community. And as many of you kind of talked about today, you know, like many of the things that we wanted to look at the health summit are really like issues like racial injustices, for example, like like why do Latinos suffer from so many physical and behavioral ailments? We felt like that's an important topic to talk about, particularly because, as you all noted, many people of Congress, many health staffers, many stakeholders in all three sectors are still denying that it exists as a problem. And we wanted to kind of set the stage and start that conversation by really looking at the big picture and looking at like the structural barriers to access to justice. We will also be tackling like many of the questions that you talked about, like including the social determinants of health, nutrition, and how that impacts a person's health. But broader issues like equitable access to vaccines, distribution, et cetera, like, and how do you like empower communities of color are things that we want to cover at the Health Summit. Like there's 10 sessions, including like the future of the Affordable Care Act and how it's going to impact Latinos. So we're hoping that you will be able to join us. Registration is free. If you go to CHCI Health Summit, you'll be able to register. I think Carlos, we sent you the link. If you could share that with everybody, we would love to have you join us for any of the sessions or even like for the entire day. It's going to be November 17th and 18th. It's fully virtual and free, and we will be joined by about 9 members of Congress, including the chair of the Congressional Hispanic Caucus, Joaquin Castro, as well as the chair of the Congressional Hispanic Caucus Institute, Congressman Ruben Gallego from Arizona.
Well, Winta, thank you so much. We really appreciate that. And it's absolutely connected to the work that we just discussed and FIU in its DNA. So thank you. So I'm going to wrap up this session. I want to thank everyone who joined. And I especially our students, lucky you guys. This has been an extraordinary conversation that I think will resonate with you all as you think about your experience in FIU in DC. I will join you at the end of the day for the close of the day today. And I expect that more good stuff is going to happen throughout your day today. So Carlos, I don't know if you have any closing comments for this session.
No, we're good.
We got a thumbs up. So we will close our panel session this morning. And I look forward to seeing the students as they continue their journey. And again, thanks to everyone who was able to join both at FIU and in the broader community for this really great experiential panel. Thank you.
Thank you so much.